subject for James. But I hope you're all keeping well. And today we are quite privileged to have Dr. James Azam from SACEMA in South Africa in Stellenbosch University, who has agreed to give us a talk, partly for the work that he has been doing. He has a nice systematic review that's out, and some of his PhD work will be presented today. James is a junior researcher at the South African Center of Excellence in Epidemiological Modeling Analysis, SACEMA, who at Stellenbosch, who we consider as a big sister, a big brother, as SACEMA here. And he has recently completed a PhD in applied mathematics. I think your last 2 years of your PhD were during the pandemic, which sort of speaks to the kind of work you've been working on. And James holds a master's in mathematics at Stellenbosch, co-funded with SACEMA, and a second master's in structured MSc from African Institute of Mathematics in Senegal, and started with a BSc in actuarial science from Kwame Nkrumah University in Ghana. His research has been mainly interested in outbreak response modeling and analytics, health data science, and policy communication, and I think he has a really nice YouTube channel that I think any master's or PhD student should look out for, because it has excellent material inclusive of how to do references and how to write in LaTeX, in case anyone is interested in that. So James, it's a pleasure to have you. I'll let you go ahead and do your talk, and we're looking forward to it.
Thank you, Tombi. Can you hear me?
Yes, we can hear you well.
Good morning, everyone, and thanks for joining today's seminar. Can you still hear me?
Yes, James, we can hear you.
Okay, so for moving forward, I won't be able to see what's going on Zoom because I have my slides up, which I'll share with you now. Trying to find the share screen. Okay, I see it. Can you see my full screen?
Yes, can see a full screen, James.
Okay, thank you. Challenges. Let me reshare my slides. Sorry. Okay, I've reshared my slides. Can you see them?
Yes, you can see them.
Okay. Good morning, everyone. So my talk today is going to be on part of my PhD work, which was on modeling outbreak response intervention strategies for decision making. So as an outline for the talk, I will tell you about outbreaks, which I don't think need any introduction, and outbreak response, and outbreak response modeling, and two studies that are closely related to the subject. And I'll provide some conclusions. So as a background, I don't think that I need to introduce what outbreaks are, but we know that they are devastating to public health, to the economy, to society. They bring a lot of things to a halt. We know, for example, that as of today, COVID-19 has caused 6.3 million deaths, according to our world in data. Ebola, which happened in parts of West Africa, led to over 12,000 deaths. Measles in 2019 alone was estimated to have caused over 200,000 deaths worldwide. And because of that, outbreak response is an essential element of public health to ensure that everyone is safe and secure and going about their daily business. And mostly outbreak response is context specific because we know that no two places are exactly the same. Even neighboring countries tend to differ in certain ways. And so you always need a lot of context to understand how to intervene or mitigate an outbreak in an area. We also know that during outbreak response, a lot of hands are put on deck. So you need expertise from academia, you need decision makers to implement whatever the academics bring out, and the decision makers, there's also the locals who will help you implement the interventions and all of that. So outbreak response is a very broad and diverse field. And that is where modeling can play a huge part. So modeling is a good tool for decision making if you can use it the right way. Some of the usefulness of modeling include like allocating resources. So if you have vaccines and they are limited, how do you allocate it to the population in a way that will maximize its benefits? You could also learn how to buy time with models. For example, with COVID, in the beginning, we had no vaccines. We only had NPIs, non-pharmaceutical interventions, and we needed to learn how to distribute that in a way that would buy us time while waiting for the vaccines, and buy us time in the sense of reducing the caseload and other effects. You can also use models to evaluate new ways of doing things. So if you have a new vaccine, for example, for an old disease, how do you use the vaccine in a way that will maximize its benefits? So all those are the uses of mathematical modeling. But we know these, but do we know if we are actually using these models for decision making in public health? So it's a question that every modeler or epidemiologist should be worried about, whether our work is, the efforts we are putting into building models are actually leading to decision making. And so we argue that one way to help us ensure that the models are leading to decision making is to have model developers who are mostly academics and decision makers like politicians and ministers of health sitting in the same room developing the models or working on the same papers. You also need experts from the affected locale to ensure that the interventions you design are tailored to the source of the affected area. So the ideal outbreak response modeling group should have a combination of these things. So a modeling group that practices these things, which should be best practices, would ideally be the best modeling group that could lead to decision making. It doesn't mean that if academics alone build models, it doesn't lead to decision making. We don't know that yet. And so to ascertain to what extent that is being done, we conducted a systematic review on how modeling groups develop models for outbreak response interventions to human vaccine-preventable diseases and foot-and-mouth disease. But I'll only highlight the main analysis, which was on human vaccine-preventable diseases. And this is currently a preprint and awaiting submission to a journal. So for that systematic review, we wanted to know how the modeling groups are distributed in time and location. And we also wanted to know whether there were differences in the way they built models between the modeling groups and how they were modeling interventions, since it's a key topic of the review. So I won't give you the details of how we did the search, but after the whole process of the search, we used systematic review methods. We searched in Scopus, PubMed, and Web of Science, and we ended up with 253 studies, 222 of which were human vaccine-preventable diseases, and the rest were foot-and-mouth disease. So for each paper, we extracted a lot of information, but of note, we looked at what other affiliation types were declared on the paper, where the affiliation types of academic institutions, of a governmental institution, or a non-governmental institution, or a combination of that. And then we looked at which country was studied in the paper and whether one of the authors on the paper was affiliated to the country. So if the affiliation declared, one of the affiliations declared was linked to the country that was studied, we would take a yes or no. And we also collected a lot of information on the model structure and the modeling methods. So this is a loaded bullet point, because we looked at whether it was a compartmental model, agent-based model, whether they use stochastic or deterministic dynamics, and all of that. Then we also looked at classes of interventions that were modeled, whether it was vaccination or non-vaccination, and the impact of vaccination. So those are the information we extracted from each paper, each of the 253 papers. So to analyze the data, we then grouped the papers according to two collaboration types. We called a paper, or we determined the paper to be the product of a purely academic collaboration if all the affiliations on the paper were from an academic institution. And we call it a mixed collaboration if it was a combination of academic, governmental, and or NGO. We also determined, so you look at all the combinations of these three, but there were also instances where only a paper had only an NGO or government and NGO. We determined all of that to form part of mixed collaborations, because model developers sitting in government or NGOs were most likely to have come from an academic background. So that was the dichotomy we created here to analyze the data. And so we did all the analysis based on these two categories of collaboration types. So I'll talk about the results. So this is just the raw counts of publications over time. And the period we looked at was 1970 to 2019. We did the first search on January 2020. And you find that pre-2005, there were not a lot of papers on outbreak response modeling relevant to the study that we were doing. Not that there were no outbreak response papers, but of modeling papers, very few. Most of the work was done from 2005 to 2019. And so it does seem to appear that outbreak response modeling, mechanistic modeling, does not have a long history in the literature that we looked at. So when we split that distribution over, disaggregated it according to collaboration types, we got this, this distribution. We first found that the literature is dominated by purely academic collaborations, but there's also a lot of mixed collaborations happening in the literature. But if you look at the blue bars, I think it's turquoise or something, this last part of the graph shows a much larger increase than the previous plot. So it seemed to appear that there were much larger mixed collaborations in the last 7 years of the period that we studied. And that was a good thing to see, that mixed collaborations are being practiced in the literature. In terms of the disease of the studies, 57% of them were influenza. And we also found that papers with 75% of the papers had an alpha in the country studied. That means we're doing a good thing, because we mostly tend to collaborate with people who are based according to the affiliation in the country that was studied. But mixed collaborations had more alphas in the location studied. So of the mixed collaboration papers, 84% of them had an alpha in the location study. So it tends to appear that mixed collaborations are practicing the ideal collaboration that we were thinking about. Other results include the types of models that were used. So we found that generally very simplistic models were used, not very simplistic, but they were mostly compartmental models, non-spatial, deterministic, and not validated with data. But mixed collaborations tended to use more stochastic models, which are more complicated to build and to keep track of. We also found, in terms of the interventions that were modeled, we found that there were 3 classes of interventions. non-vaccination, which were mostly non-pharmaceutical interventions, and then 2 ways in which vaccination was modeled. It was either modeled alongside other interventions, but not compared. So, for example, you'd build a model, look at the use of vaccination and non-pharmaceutical interventions in conjunction. And then there were a third class of papers that looked at the sole vaccination as a sole intervention. So we are only using vaccination as an intervention during this outbreak. And that was interesting because we only found 10% of the studies that did that. Because we're interested in looking at the impact of vaccination when you use a model as the assessment tool. And considering that all the papers are vaccine-preventable diseases, it was quite surprising to find only 10% of the studies modeling vaccination as a sole intervention. And it also goes to show that vaccination does not act alone. It always acts alongside other types of interventions to achieve maximum benefit. There were 4 studies of the 10%, 23 studies were the 10%. 4 studies found on antivirals and isolation to be better. That meant it was mostly influenza papers. But for those papers, they modeled some challenges associated with vaccine implementation, including the delay to develop vaccines, low vaccination rates, or having a very low efficacious vaccine. But in those papers, they also concluded that you can implement these antivirals and isolation until you have vaccines, then the vaccines take over. So they still pre-assume that vaccination would be effective. So in summary, we found that the human vaccine-preventable diseases literature, outbreak response modern literature, is dominated by purely academic collaborations. But in the past 7 years of the period we studied, there was an increase in mixed collaborations. And we also found that the mixed collaborations tended to include more local experts and used more complex methods like stochastic dynamics and model validation with data, which is harder to implement than not validating your model. So that's the summary of, that gives you a glimpse of what the literature looks like with outbreak response modeling. So as a very specific case, we built a model to look at the benefits of using measles vaccine outside of cold chain for outbreak response. And this is a special case of outbreak response. And I don't think that measles needs an introduction, just like outbreaks. Currently, as we speak, South Africa has declared a measles outbreak. In 2020, a paper came out talking about all the outbreaks that occurred in 2019, data as of March 2020. And there were many outbreaks around the world leading to many deaths and cases. And measles is important because it has a very high R naught of between 12 and 18 that we found. So, and it leads to high mortality. But the issue with measles is we've always had a vaccine that is cheap, safe, and effective. And so you don't understand why measles should be a problem as of this time that we are at. The problem with measles is not that we don't know much about it, but what we know about it is that the vaccine is difficult to handle, just like any other vaccine. And if you couple it with the speed at which it spreads and the logistics involved in getting the vaccines to an affected location, it becomes a complex issue that goes beyond some of the things that we know. Just like any vaccine, when the measles vaccine is manufactured in a factory somewhere in Europe or India, it's flown to a national store, and I'm sure a number of us are aware of the supply chain. It flows to a national store. It's driven to a regional store, and regional could be provincial or something, and there's many layers in between these things. Is then transported to a clinic, and then it is transported to a remote location, mostly in low-income countries. So the issue usually is that transportation from the clinic to the remote village becomes problematic due to the supply chain issues with transportation. And I'll show you a picture of how sometimes it looks how it looks in pictures. So this is just a picture of a health worker ziplining somewhere in Pakistan to get the vaccine to a village. There's somewhere in South Sudan where they have to canoe, transport the vaccines in these boxes in a canoe to a village somewhere on water. And there's many other examples. So that is the measles problem, how to transport the vaccines to people on time. Recently, a paper came out that said, I think what I forgot to mention is that you need to maintain the vaccine in the cold chain in this box. So you need ice packs that will keep the vaccine within the temperature of 2 to 8 degrees to transport the vaccines. And it's heavy and it has all those issues. So recently, a group of collaborators of ours reanalyzed measles vaccine stability data from the Serum Institute of India. And they found that the measles vaccine remains stable for 6 days when it is reconstituted at an ambient temperature of 37 degrees Celsius. So when you take the vaccine out of the cold chain and the ambient temperature is around 37 degrees Celsius, the vaccine will remain stable for 6 days. But if the ambient temperature is around 40 degrees Celsius, you can use the vaccine for up to 2 days without putting it back on ice. And so there's a lot of documentation on what this means. And what this in principle means is that you could use it outside the cold chain for those prescribed number of days. Now, the logistical benefits of doing this with the measles vaccine is that there will be a reduced cold chain, because freezing ice packs and maintaining the cold chain is really a hurdle and it takes a lot of time. So when you reduce the cold chain, it saves you time that can lead to rapid responses. And that also means when you throw out the ice packs from the cold boxes, you have more room to transport more vaccines. And more vaccines is always good news. But there's a logistical challenge associated with the measles vaccine in particular. For some other vaccines like meningitis, they were able to do it with a many dose vaccine. But for measles, the data that was analyzed showed that you have to switch, for now, we have to switch from the 10-dose vaccine to the 1-dose vaccine. So for the same container of vaccine, the same vial, one allows you to vaccinate 10 people or take out 10 doses, and one allows you to only take out 1 dose at a time. And that means that for the measles, you have to switch from using the 10 dose in full cold chain to using just the 1 dose, same size container. And that means that you still need more volume if your equipment are not enough to fit the number of doses that you need for a trip. And so the objective of this study was to evaluate the operational and epidemiological benefits of using the measles vaccine outside cold chain for outbreak response. So to answer that, we developed a modeling framework that combined an SEIR model that would allow us to estimate the epidemiological benefits and a supply chain model to take into account these problems that I've discussed. So there's always a pre-deployment delay, like the time it takes to transport the vaccines from the national level all the way to the clinic. There's a delay to commence a campaign. When you get to the clinic, in some supply chains, you still have to set up field bases in the village where you have freezers to freeze the ice packs. And to prepare the teams, you have to meet up with the teams and prepare them and prepare the ice packs for the campaign. So there's that delay. And in each location you go to, you spend some number of days there. So There's also a campaign delay there, and also vaccination coverage pertaining to whatever vial or vaccine vial you're using. So we built a framework that accounts for all these delays and the fact that the outbreak is still ongoing. And so there's an epidemic happening and there's a supply chain aspect of the campaign also happening at the same time in parallel. And when you combine those two in our framework, it spits out a campaign, cases averted, that's how many cases are prevented given an intervention compared to if you had no intervention. Vaccination coverage that you can achieve, which is it's a supply chain outcome or operational outcome, because you want to know how many people you can vaccinate given a certain strategy and how long it will take. So the total campaign duration is also important, especially in terms of cost, because you have to pay workers and all of that. So a shorter campaign is always better. A shorter campaign is also better for measles, given a high vaccination coverage because of the speed at which measles spreads. So that is also important. So the model, this is just a simplified version of the supply chain that our model took into consideration. There was a provincial or district store. We didn't explicitly represent these, but we explicitly represented the last mile of the campaign, which is a field base, which is a lower level than the clinic, where you have freezers and fridges and vaccines and teams, and you have locations that you have to go to and return to the field base for replenishment. So you have several locations. So this is the part that we cared about in the model, even though we subsumed this part into a component of our model. So in the model, we accounted for the causes of delay from this top level to this gray area as the pre-deployment delay, and the delay from the field base to go to a location was considered as the commencement delay, and it takes into account the ice freeze and all of that. Just to provide context, we also looked at two team equipment that are used on the field. I'm sure some of us are familiar with these. There's RCW25, which is a large box. It's like this freezer-like thing you use on the field, but it's not electronic. It just takes a lot of ice packs and takes a lot of vaccine. And you have the vaccine carrier, which I showed you in the picture. So this is mostly for walking and for short distances and for easy transport. And RCW25 is mostly for storage. So we set up strategies that combined the use of a vaccine type, a mobile team equipment, and a type of cold chain. The vaccine type, we looked at whether you're using a 1-dose or a 10-dose vaccine. The mobile team equipment, we looked at whether you're using a vaccine carrier on RCW25. And for the cold chain, we considered that you're using the vaccine and equipment with a full cold chain, meaning you are going to use ice packs from the beginning to the end of the campaign, which is the same as what is being done currently. Outside cold chain, which means you throw out the ice packs and only use the vaccines, keep the vaccines, and a combination of the two. So you use full cold chain on part of the campaign, part of the campaign in the urban areas, and the outside cold chain for the remote campaigns. So because you have to go far, you throw out the ice packs, or you split up the teams. You have teams that will stay in the urban areas where there's electricity and constant supply of electricity. And so you can have a full cold chain there and it's not a problem. But when you're going, the other part of the team that will have to go to the remote locations will use an outside cold chain. So broadly, we looked at comparing three strategies: the full cold chain, which I explained, outside cold chain, and a partial cold chain, like I explained, where you have a combination of the two. So we simulated outbreaks in 5 identical locations that had the same timing and characteristics. We deployed 20 teams to move sequentially through 5 locations. So they go to location 1, finish it off, and go to location 2 and location 3, and so on and so forth. In each location, we had 75,000 people in the urban area, and 25,000 people in the remote area. And we assumed that it would take 21 days for the vaccine to get to the field base. So for we simulated 10 strategies in all. Were there 10? Yeah, 8 strategies, sorry. We simulated 8 strategies in all. And for each strategy, we estimated how long it would take to complete this campaign with that strategy, what vaccination coverage you would achieve using that strategy, and how many cases you would avert using that strategy. So for the results, keeping in mind that, one constraint we put on the system was that you're only allowed to run a campaign for 10 days in a single location. And this is based on field knowledge that in some places, the government do not want you to spend too long in an area. So for each location, you're only allowed to spend 10 days. And so that's formed part of like a fixed component of the campaign duration. This plot is a bit complicated, but I'll try to summarize it. So here I'm showing the results of the simulations. You have vaccination coverage on the y-axis against campaign duration. The best strategies would have a short campaign duration and a high vaccination coverage, like I mentioned earlier. And we can see that the orange strategies, which is the outside cold chain strategies, take shorter to complete and achieve a high coverage, even though all the strategies achieve similar coverages, except for one of them. The partial cold chain strategy achieves a 1-day difference of campaign duration, and the full cold chain strategy achieves a 2-day difference. But the shortest time you could take for a 5 location campaign is 50 days if you're going sequentially with such few number of teams. We also looked at the cases averted, like I mentioned. So we compared the currently used strategy, which is the full cold chain strategy, the blue one, using the vaccine carrier with the 10-dose vaccine. And this is the 0 line. So we compared all the other strategies to that strategy and found that all the cold chain strategies were the same as what is being done. So you don't need to change anything. One of them was really bad compared to that strategy, so you don't even think about it. The ones above the line were doing better than the current. Partial cold chain led to about 1,000 more cases averted, and the outside cold chain strategy led to about 2,000 more cases averted compared to what is happening. It didn't matter the vaccine type you were using. It didn't matter what equipment you were using. In order to not deceive ourselves that this looks so great, we decided to do a sensitivity analysis on if you don't have control over how long it would take for the vaccines to get to the field base. So we initially assumed that it was 21 days. And we are comparing it based on how many cases would be averted. So if we realize that it's due to the scale, it's hard to see the differences here. But what you can see is that the strategies get very similar in terms of cases averted when the delay it takes to deliver the vaccines to the field base grows. So when this is like about 3 months, if the delay, it takes about 3 months to transport the vaccines all the way to the field base, then you're basically, all the strategies are going to be similar and it won't matter which strategy you use. So time is of the essence in terms of that delay. We also looked at how you would allocate the teams over the locations. We looked at that in terms of what the campaign coverage would be if you have 500,000 people in total. And we found that if you distribute the population equally, if you distribute the teams equally, like you split, if you have 20 teams, split it 10, 10 for those in the urban, and 10 for those going to the rural, irrespective of the size of the location, then you would not have, in some cases, you would not have a high enough coverage. But if you always allocate your teams proportional to the size of the two destinations you're going to, then you'd increasingly experience a benefit in the vaccination coverage. So in summary, I've shown you how you can also use modeling to answer a practical question about a new way of doing something. And in this case, we found that relative to what is being done, the new way of doing something, or two new ways of doing the same thing, that's a spatial cold chain and outside cold chain strategies, could lead to a shorter outbreak response vaccination, high vaccination coverages, and more cases averted if you deploy your teams quickly. And so those are the benefits of the new strategy, and these are good results that could lead to a change in the way we respond to measles outbreaks, given that we are not even changing anything about the system. Everything that has been studied here is the same old system, but a new way of doing things. So I'm just going to conclude in general. For the systematic review that I talked about, there's more room for mixed collaborations, as we see that it's still dominated by purely academic collaborations. And we think that increase in mixed collaborations over the past 7 years could suggest that there was modeling is being recognized in decision making, and there's probably an increase in the way that decision makers and model developers are working together to create models or to create modeling results. And we know that mixed collaborations, if they operate this way, are closer to the ideal and could help ensure the uptake of modeling for decision making. And the systematic review itself is useful as an overview for the field. If you're new to the field and want to learn about the models that have existed before and how people have made choices in terms of building models, it's a good resource. For the measles case study, we found that the cold chain presents many challenges to its control, and outbreak response outside of cold chain could present better operational and epidemiological benefits. And outside cold chain strategies, like I showed you the pictures, could ease the trouble that healthcare workers go through to ensure that communities are vaccinated against measles. So I'd like to thank my supervisors, Prof. Matt Ferrari from Penn State University, Prof. Juliet Pulliam, who is on the call currently, I think, my many collaborators, Kimberly Bona and Barbara Saita were with MSF at the time that we were working on this project, but they've since then moved to new places. Dr. Elisha and Xiaoxi Pang, and SACEMA funded my PhD. And I would also like to thank you all for listening. Here are my contacts if you want to get in touch. And I would like to thank you all for listening.
Well, many thanks, James, for a really fascinating talk, both on the systematic review and the work that you have done on measles outside of cold chain. I'm sure we have just about 10 minutes of questions.